Thank you for inviting me to this conference. So today we're going to talk about the delay of total knee arthroplasty when using hyaluronic acid and viscosupplementation. And I think everyone here agrees one of the two main parameters around continuing progression of osteoarthritis is the fact that in OA, articular cartilage is avascular and aneural, and that helps contribute to the fact that patients end up developing total knee arthroplasty. If you look in the U.S., we have a troubling paradigm starting to develop. You can see the amount of total knee and total hip arthroplasties that are coming our way. And for those of us that are fellowship-trained total joint surgeons, we are not going to be able to handle the amount of volume coming towards us. And so are there opportunities to change the natural history and disease progression over time? One of the other big concerns with this graph is not only primary total hip and total knee, it's the revision burden as well, right? Because we know, for example, we have around a 2% infection rate. We have complications that go along with arthroplasty. So not only is the disease burden affecting, from a value perspective, primary total joints, but the revision burden is going to be substantially higher as well. So when we look at the current paradigm, most of us are using cortisone or betamethasone or some kind of steroid in terms of our injections to manage knee OA. But remember, most of us do not inject steroids in isolation. We combine them with various analgesics. And so if we look at some of the basic science in vitro preclinical work, what we find is almost 80% cell death with 2 hours of exposure of steroid plus analgesic. Right? And so we know our current process, our current paradigm, while being cheap and cost-effective, may potentially be causing some biologic disadvantages. So this is a recent study demonstrating the impact not only previously in the preclinical model, but now we see the impact of steroid injections in the clinical space. So this is one of the premier journals that we all know. And if you look, if we inject steroids every 3 months for 2 years compared to saline, we then do an MRI, you see a reduction in articular cartilage volume, right? So this is some powerful evidence that goes along with the basic science that we see. So we have to link up the preclinical information with the clinical to then justify and really understand what's going on. So this was a recent study that came out looking at the impact of viscosupplementation on the meniscus. Now, those of us that do arthroplasty, what we appreciate is actually the impact of the meniscus and OA progression, right? And so if I look at the number of total knees that I've done over the last 12 years, very few are post-traumatic from tibial plateau fractures or distal femur supracondylar fractures. Majority of our total knees that we're doing, usually if you ask the patient, it's usually post-meniscectomy, right? They've had a knee arthroscopy, they had some kind of meniscus damage or meniscus issue. Those are the patients developing knee OA. It's not the patients with tibial plateau fractures and screws growing across, especially if the meniscus is preserved. And we're starting to see some early data at the impact of HAs on the meniscus, which arguably may be the most important anatomic structure in delaying OA progression. So everybody loves these guidelines from the AAOS. And so if we look at the AAOS guidelines, what did we find? There's only 4 positive recommendations, right? NSAIDs, weight loss therapy, and osteotomy. So from a clinical perspective, it's not very practical. Steroid injections have a neutral recommendation. HA injections had a negative recommendation. And what was the impact of that in the United States? The impact was the insurance companies started denying viscosupplements and HA injections, okay? So what I wanted to do with our research was look at this from the payer perspective. As you saw earlier, how do we define success? So one way of defining success, especially from the perspective of the insurance company, right, because mostly what they think about is money, what's the one thing that may get the insurance companies to change their mind? It's potentially impact on high-cost, high-volume procedures. What is that? Total knee replacement, right? So if we look at the impact of HAs on total knee replacement, we may be able to change some of the policy and some of the aspects of the way insurance companies are behaving. So if we look at the literature, this was out of Spain, right when the AAOS guidelines came out, they did a cost-effective model, and what they found was an improvement in those patients that had HAs versus those patients that didn't in terms of impact to total knee replacement. So I wanted to look at this in our research and understand what was the impact of HA injections in our insurance claims databases. So what we did was we looked at, within this database, all the patients that had a knee replacement. Then we looked backwards, 6 years, to see who had HA injections and what was the impact of those HA injections on time to total knee replacement. So you can see this database had 79 million patients. We found 328,000 patients that had total knee replacement that met our inclusion criteria. 50,000 patients were HA users, 131,000 patients non-HA users. And again, the patients had to be continuously enrolled in that insurance plan. They couldn't have left. They have to be continuously enrolled so we capture exactly what happened during that entire course. And what did we find? What we found was patients that received 5 courses of HA treatments or more had a 3.6-year delay to total knee replacement. Patients that did not receive HA injections, you can see the time here. Okay? So this is a pretty big impact on delay of total knee replacement, but this was looking retrospectively, right? You had to have a total knee replacement, and then we looked backwards. So I'll show you our secondary study after this in a minute. This was out of Dr. Waddell's lab in Louisiana, actually in Shreveport, Louisiana. Now, this is a single surgeon database. What he looked at was the impact of Synvisc on his time to total knee replacement. So these are KL4s, right? We would expect these patients for HA injections to not work as well. But what he found in his database, almost 1,400 patients that had total knee, 465 patients that did not, and he modeled this out. And what he found with this product, almost a 3-year delay in the patients that were exposed to HA versus the patients that did not receive HA. So this is, excuse me, another database research study out of France. And you can see here 14,000 patients with knee OA, 1,600 patients that had total knee replacement, 9,400 patients had hyaluronic acid, 5,300 patients did not have hyaluronic acid. And what did they find? If you did not adjust for various patient comorbidities, there was approximately 7-month delay with HAs in time to total knee replacement. If you look at the patients where you adjust for the various comorbidities, approximately 2.3 years of delay with time to total knee replacement. So this is a study that was recently accepted by our research group. Hasn't been published yet, but was accepted for publication. We did another study now. Remember in the first study, we looked retrospectively for 6 years. For this study, we wanted to look prospectively in OA patients and see who ended up with total knee replacement and how long it took. So this is a study of 1.5 million patients in that research in the claims database. 50,000 patients received HA injections. And again, like I said, we followed them for 3 years. They had to have continuous enrollment. They couldn't have dropped out of that insurance plan. We had a look-back period where the patient had to have a new diagnosis of OA within 18 months of being enrolled in that index study. So you had time 0, we looked backwards. We only picked up new OA patients, so that way we knew they didn't have some previous treatment previous to that time. Time 0, and then we looked forward on the knee OA patients for 3 years. We looked to see the impact of HA injections on time to total knee replacement. And what did we find? What we found was almost the exact same thing with our original research study. The more patients were exposed to hyaluronic acid injections, the longer it took to total knee replacement. So if you see here, 95% of the patients were total knee free, if you will, after 3 years when receiving multiple HA injections. 71% of the patients were TKA free, if you will, after 3 years when only receiving 1 HA injection. Now, I have a couple slides I didn't put up. We're in the process of submitting a manuscript actually next week, looking at the cost effectiveness of HA injections compared to total knee replacement and steroids. And what we found was HA injections had a significantly reduced impact on cost compared to steroid injections and total knee replacement, as you would expect. Total knee replacement was our control. Additionally, what we found was far fewer complications in patients that received HA injections compared to steroid injections. And what was interesting in terms of opiate use and narcotic use, total knee replacement and, as you would expect, 1 year out from surgery had high narcotic use, then steroids, then HA. After 1 year, actually, total knee patients and HA patients had the same opiate use, narcotic use, but steroid use was higher compared to those two groups after 1 year. So that research we hopefully will be submitting next week, and then hopefully will be available for you for publication if and when it gets accepted. So with that, I will conclude. Thank you.